bring you greetings from the Apollo Proton Cancer Center, and today I will be discussing about the outcomes in breast and head and neck cancer and our experience at the Apollo Proton Cancer Center. So before I start talking about the work that we are doing here, this is the Apollo Proton Cancer Center. We are a complete comprehensive cancer center offering, besides proton therapy and tomotherapy, we also have facilities for surgery as well as chemotherapy and intensive care with facilities for surgery across various branches such as head and neck, breast, gynae, and neurosurgery, urology. However, the focus of my talk is proton therapy. And I'd like to start by telling you a little bit about what proton therapy is. And for this, I have a little cartoon here. So this white is the tumor. And when we are treating with normal X-rays, what happens is that the X-rays attenuate as they go through the body, and they pass through the tumor and continue to pass through the body. However, with proton therapy is a positively charged particle, and it expends its energy at a predefined place, which means if this is the tumor, nothing else goes beyond the tumor. And therefore, if we want to cover the tumor, we will use a certain number of energies. In this case, in this cartoon, I have used 3, but we may use up to about 30 energies or more to cover the tumor fully, which results in this, which is called the spread out bright peak, which means that while the tumor is being covered entirely by radiation, and there is some radiation proximal to the tumor, there's nothing else that's going beyond. And that is what we are exploiting when we are using patients for treating with proton therapy, which means because nothing is going beyond, it allows us to spare normal structures that may be lying beyond the tumor. It may allow us to give a higher dose. And in certain situations, because the proton is going and depositing all its energy very rapidly, it leads to damaging the DNA by causing double-strand breaks. And because of that, radiobiologically, it may lead to a higher cell kill. Proton therapy, in spite of the fact that it's so useful, but there is a certain technicality. The equipment is very complicated, and there aren't very many centers in the world. And we are actually very privileged, I should say. It is our privilege to be a part of the group that is bringing proton therapy to this part of the world, which so far has not had access to proton therapy. And this is our center here. So the first center in South Asia, Southeast Asia, as well as Middle East. And I'll go straight to the topic at hand. What is its use in breast cancer? And for this, I'd like you to look at these 2 diagrams. Now, this is a isodose of a patient of breast cancer treated with proton therapy. And this is the dose color wash of a patient of breast cancer treated with another very good technique, which is tomotherapy. So now we know that what we want to treat is this red line, which means this is the left breast of this lady. And what our dose prescription is covered in yellow. And everything else which is not yellow, which is lavender or which is pink or which is blue, is extra dose, which we do not wish to deliver to the patient. So in spite of the fact that the tomotherapy is a very good plan, we find that, yes, there is a lot of spill that goes into the chest wall, into the lung, on the musculature of the heart, as well as the opposite breast. And in proton therapy, we don't see that happening. And that really is not an oversimplification. That is really what it is. And what is the impact of that? The impact of that is, for example, when we see the mean dose to the left anterior descending artery, we find that in a tomotherapy, in spite of a good, machine, we still are able, the mean dose is about 6 gray, but critically, in a certain segment of the left anterior descending, the dose may go as high as 26 gray. In comparison to that, in protons, we are able to reduce the dose to less than 4 gray. And this is really the crux of the issue. Why is it the crux of the issue? It is the crux of the issue because a good number of breast cancer patients, even in third world countries like ours, do survive for 10 years and 15 years and longer. And that is when their heart problems or the issues arising because of irradiation start becoming obvious 10 to 15 years later. So this is the kind of technology that is used. The earlier technologies for protons were different. This is a very sophisticated technique called the pencil beam treatment. And in this, you can see it's literally like spots. We are treating the entire tumor with spots, layer by layer. And because we are treating with spots, we are actually able to, conform to the shape, whatever we want to treat. So, of course, for breast cancer, we know that adding radiation in a post-mastectomy setting is helpful even in patients with 1 to 3 lymph nodes positive. Of course, it is mandatory in all but the very senior citizen who undergoes a breast conservation treatment. So both in post-mastectomy setting as well as post-breast conservation, there is an indication of radiation. And this, of course, we know also translates into better survival. But the impact of that, and this is the latest study which has come from Korea, this was in December 2020 in the Red Journal, and we find that firstly, that the dose to the left side of where we are treating the breast, we find that a significant number of left-sided breast cancer patients will have doses higher than 4 to 5 gray. If we are treating the internal mammary nodes, the number is very much higher. If we are not treating the internal mammary node, even then, a significant number of patients will have a mean heart dose of more than 4 to 5 gray, and certain number of right-sided breast cancer patients will also have a dose which is more than 4 to 5 gray. And this is typically the patients in whom we are treating the internal mammary nodes, which means anyone with a positive axilla or anyone with a central or a medial quadrant tumor. What does it lead to? It leads to a higher risk of breast cancer-induced heart disease, especially in patients who have hypertension, in patients who have diabetes, and who are not exercising. So exercise is protective. That is a very important point to note. And of course, the other factor it is related to is the mean heart dose. And in patients who have 2 to 3 risk factors, the risk can become as high as 10 to 12% at the end of 10 years. So there are, in the past, of course, we know there is a difference between right-sided and left-sided breast cancer patients. Left-sided breast cancer patients have a smaller freedom from coronary artery disease, smaller freedom from myocardial infarction, and a different pattern of involvement. So they are more likely to have left anterior descending artery involvement. Unlike other women, in other women who have not had radiation, there is an equal distribution between the left anterior descending, the right coronary artery, and the circumflex. The reasons are both endarteritis, myocardial fibrosis, pericardial fibrosis, problems in the conduction pathways in the heart. So basically, a macrovascular injury as well as microvascular injury. And of course, this is a celebrated paper from Darby et al., which told us that every gray that we give to the heart increases the risk of developing a heart problem by 7%. The risk is 6.6 times higher in patients who have had a previous ischemic heart disease, and double in patients who are obese or diabetic or hypertensive or smokers. They did not look into hyperlipidemia and family history, but I'm sure that is relevant also. We also have to remember that a lot of these patients will have cardiotoxic chemo in the form of adriamycin or taxanes, etc. We also know that when we give a higher dose to certain segments, for example, septal part of the ventricle or the apical part of the ventricle, the risk of having a left ventricular injury is higher. So this is a study in JCO of 468 patients. And again, another study where the correlation of the cardiac stenosis site with the radiation dose has been done. So to cut a long story short, radiation that is received by the heart does have long-term implication. Of course, there are techniques, and this is something that I was doing in Delhi. Before I moved to Apollo Proton Cancer Center, I was practicing in Delhi for the last 24 years. And we were one of the earliest units to start deep inspiratory breath hold to reduce cardiac doses in breast cancer patients. So in deep inspiratory breath hold, we know that we create a distance between the heart and the chest wall by making the patient hold her breath in deep inspiration when the treatment is being done. And we see that it leads to a reduction in the V5 gray to the heart, V25 gray, left ventricle, mean dose to the left anterior descending, max dose to the left anterior descending. But I have this here not to talk about deep inspiratory breath hold, but to tell you what is the impact of doing proton therapy vis-a-vis deep inspiratory breath hold. So proton therapy is really very simple. This cartoon will tell you straight and on fast beams. And the beauty of it is that it does not pass beneath the rib cage. It doesn't go into the heart, it doesn't go into the lungs. So the difference is this. Red is what you achieved with photon-based treatment, whether with breath hold or not, and blue is what is achieved with proton. So you can see less than 1 gray mean dose to the heart. And this is our first patient. So I'll show you this. This is proton, this is tomo. Coverage equivalent, boost dose equivalent. But when we come to the cardiac doses, that's when you start seeing a difference. So look at this. This is the coronary left anterior descending artery. And this is the left anterior descending artery when we treat it with tomotherapy. So basically, it is receiving 22 gray. In spite of a good treatment plan, it is still receiving 22 gray. Vis-a-vis in proton therapy, we see that the 22 gray isodose is quite far away from the left anterior descending. This is the outcome on completion, very good skin reactions, cosmesis is satisfactory. And this, I come back to now explain to you how proton therapy is able to restrict the dose to all these structures as compared to tomotherapy. The impact on left anterior descending, I have already told you. These are the parameters on the heart. So 1/10 V5, the cc number of the volume receiving V5 is 1/10 as compared to tomotherapy. V25 is also significantly less. And V5, very, very relevant, is dramatically less, as you can see. Now, V5 is now when we compare it to the same graph that I had shown you earlier, that's when the quantum becomes obvious. So when we look at V5 of the heart, instead of 36%, it becomes 4%. That's almost like 1/10 of the dose that is being received. Similarly, mean dose to the left ventricle comes down from 6 gray to 0.12 gray. So I am very clear that this fulfills the basic, when we sit down to make a radiation plan, what is it that we are trying to do? We are trying to make sure that the target is covered properly and the dose is being reduced to normal structures. So it fulfills our basic principles of radiation oncology, which is called ALARA, as low as reasonably allowable. What is the impact of this reduction of the left ventricular V5 gray? You can see 0. So this 40 gray that what we have achieved previously, this 36 gray that we have achieved previously, 44% here, the left ventricle, is going to make this patient, in spite of deep inspiratory breath hold, have a 12% excess risk of having an acute coronary event versus 0 with proton therapy. And this basically is what proton therapy is able to do. These are some other patients we had treated. We very dutifully make all the coronary arteries, all the left ventricle, all the segments of the left ventricle, and so on. And as you can see, the same story, the green that you see is 10 gray. So it's really not even 10 gray is going into the lungs and the heart. And this is the impact of that, the mean heart dose that we have achieved for left and right side, 0.9 gray, 0.56 gray, and also a significant reduction in the dose to the lungs, which will translate into a smaller risk of having a second cancer, very relevant in young patients. So when we have these 25, 30, 35-year-old TNBC patients coming to us, we all know that after they've passed the first 2 years, their survival is actually not bad. And that's when it becomes relevant. This reduction of almost halving of the mean dose to the lung becomes relevant. So as you can see, contralateral breast dose, this is with the tomotherapy plan, this is with the proton therapy plan. Lung dose, as I already told you, the volume receiving 1000 centigrade is about 45%, and here the volume receiving 1000 centigrade is about 22%. So a significant difference in the reduction, which translates into a reduction in the risk of developing second cancer. Even so, I showed you 3 tomotherapy, but this comparison is with tangential 3D CRT, which actually may reduce the dose to the normal structures such as lung or opposite breast even further. And then also we see that the second cancer risk comes down with proton therapy. So there are multiple studies which tell us that the risk of developing a second cancer comes down with proton therapy. And there are a number of studies. So this is the most recently published phase 2 study, which looked at 70 patients. This has been done at Mass General Hospital, and we can see the locoregional failure is very low. The overall survival at the end of 7 years is 91%. And there are multiple studies. So one interesting application is bilateral breast disease. In bilateral breast disease, adding proton therapy naturally decreases the risk of developing pneumonitis and cardiotoxicity. There are multiple dosimetric studies, and there are a number of clinical studies also now from a number of places in the Western Hemisphere. It is now also gaining traction in Europe, where the Danish breast cancer group has recently started enrolling patients, as well as the Maastricht from the Mastro group has also, in Maastricht, they have also started enrolling patients for proton therapy for breast cancer. As you can see here, proton therapy doses, mean heart dose, mean LAD dose, a repetition of what I have already told you, various techniques, 3D CRT with internal mammary lymph node. Of course, the maximum benefit is with internal mammary lymph node treatments, helical tomotherapy and VMAT treatments. Proton therapy scores in all this. There are, as I said, there are multiple other studies which are outlining the same fact. And there are a number of clinical studies. So this is a clinical study. Again, as I said, the mean dose to the heart is in the range of 1 gray. Routinely, if we are not using deep inspiratory breath hold, the mean dose to the heart is in the range of 5 to 8 gray. If we are using deep inspiratory breath hold, it comes down to the range of 3 to 4 gray. And with proton therapy, it comes down to 1 gray or less. Similarly, the mean dose to the lung is about 12 gray. That comes down to about 7 gray. So this is where we are about heart patients, breast patients, in diabetics, in hypertensives, smokers, patients with previous ischemic heart disease, as well as in young patients who have a longer expected survival. We are obviously talking about the next 10 to 15 years. We have recently started a registry called the HiPro-B registry. The HiPro-B registry is looking at a 3-week fractionated course of proton therapy for breast cancer. We are treating both right as well as left-sided breast cancer patients. And we will be documenting their cosmetic outcomes. And of course, we will be following them with the global longitudinal strain on echocardiogram. We will also be checking their outcomes. And the results of our initial few patients has been very, very gratifying. We have, in fact, treated a young lady, a 29-year-old, where there were concerns about the second cancer risk arising from her treatment. It has been very, very gratifying. I know that this is a breast cancer study group, but I would like to tell you a little bit about head and neck cancer also, especially because the gains in proton therapy in head and neck cancer are so significant. So in head and neck cancer, we know there are a number of organs at risk that we wish to protect. Why do we wish to protect them? Because in the critical organs like spine or brainstem, they can impact the dose that we can give. And for all other organs, this has long-term implications on the quality of life. So, of course, there is intensity modulated radiotherapy that paved the way for sparing normal structures to be able to improve the quality of life of our patients. And for proton therapy, what it does is, now this is a patient with oropharynx cancer. This is a proton therapy plan. This is nasopharynx cancer. This is a photon plan. This is the extra dose that a photon plan gives to a proton therapy patient or to a nasopharynx patient. And that translates into increased risk of tube feeding, increased risk of aspiration, increased risk of opioid requirement, hospital admission. All these become less. There are multiple studies. For paucity of time, I am not going to go into the studies, and I will go directly into the patients whom we have treated at the Proton Center. So this is generally what proton therapy allows us to do: improve the quality of life, especially in the elderly and the young, but otherwise actually in all patients. It allows us to re-irradiate, increase the dose, and in adenoid cystic carcinomas and paranasal sinus tumors, it also leads to better outcomes. There are multiple studies that tell us that it leads to better outcomes. I'll show you this 40-year-old lady. She presented with blindness in one eye because she had this tumor that was encasing the optic nerve. This is how we treated her with proton, spared the optic nerve on the opposite side. And this is this patient. She has completed 1 year post-treatment, and she has recovered vision in the affected eye. We are hoping that we will be able to maintain the vision. We're giving her some Trental, etc., so that even on this treatment side, we are able to maintain the vascularity and hopefully the vision even on the treated side. But definitely, it has been very gratifying. There's another gentleman, adenoid cystic carcinoma. In his case, the tumor was in proximity to the right optic nerve, and you can see the before and after pictures. He too has completed 1 year post-treatment. His vision is maintained, and he is disease-free. Paranasal sinus tumors, you will see that the outcomes are excellent. 80% control at 2 years. And this is in comparison, if we see the same, much less when we use photon-based treatments. So again, excellent 3-year local regional control rates, even in paranasal sinus tumors, which is a bad tumor. And I'll show you another gentleman, 38-year-old. I'll skip straight away to the before and after pictures on the PET scan. And that is really, so very gratifying. So this gentleman had come today in the morning. So we finished his treatment in March last year. He's 10 months post-treatment, disease-free, doing well. Again, very gratifying. And this is the story that we often see in paranasal sinus tumors. Quality of life. Why is quality of life better with proton therapy? Because the sparing of the mucosa is better. So you can see the posterior pharyngeal wall here, and you can see the larynx here. In this young man, 39-year-old with a CA tonsil, he was P16 positive, which means that he's going to have a longer life, he's likely to do better, where it becomes even more important to preserve his quality of life. And as you can see here, the 35 gray and the 21 gray isodoses are sparing the midline mucosa, and we expect that to translate into long-term better quality of life. The same before and after picture of this patient. And as you can see, the reduction in the dose may vary from anywhere between 10% to up to 50% reduction in the dose being received by the normal structures. Elderly patients, mucosa of the palate being spared. We can see here the proton therapy plan is sparing the mucosa on the palate. Here the tomotherapy plan is treating the mucosa, and in this patient we were able to spare the mucosa very nicely in this 80-year-old patient. This is just 2 days before treatment got over, and you can see that there is virtually no mucositis. In contrast, in the young patient, we don't want to treat because they can have second cancer 15, 16 years later. This is a young man with a mucoepidermoid carcinoma. We can see the cheek being spared and the soft tissue being spared. These patients are even prone to develop soft tissue sarcomas, osteosarcomas post-treatment. This is the tomotherapy plan. The cheek mucosa is receiving 30%. The musculature is receiving 10% of the prescribed dose, while in the proton therapy plan, both the cheek mucosa and the musculature have been spared so nicely. Another very important indication is re-irradiation. Now, this is a young lady. She's in her mid-30s. She had received treatment 6 years earlier for an esthesia neuroblastoma, and her optic nerves had already received radiation. So to spare the right optic nerve, we would have had to underdose the tumor if we had treated her with tomotherapy. However, with proton therapy, we were able to protect the optic nerve and still give the right dose. She remains disease-free. And this is going to be nearly 2 years post-treatment, 1.5 years post-treatment. She remains disease-free. Of course, we have treated the left optic nerve, and she does have some impact of that, but the right optic nerve and the optic chiasm have been spared very nicely. Another re-irradiation patient, tonsil, retreatment, sparing of the opposite buccal mucosa as compared to the tomotherapy plan. The green is the 30% dose, blue is the 10% dose. Nothing goes to the contralateral side in this patient when we are treating with proton therapy. So what do we want for our patients? What we want is them to have longer lives free of cancer. Proton therapy allows us to dose escalate and allows us to exploit radiobiology. And what do we want them to have? Longer lives free of cancer, but we want it with their quality of life intact. And that is what proton therapy allows us to do, both for breast cancer patients and head and neck cancer patients. Not just for head and neck and breast cancer patients, but for many other sites. But for that, there will be another day for discussion. So, of course, it is not just the doctor which does it. In any cancer hospital, in any cancer department, and in any radiation department, it is a team that does it, and this is our team. So this is Dr. Jalali, our medical director, who's an internationally renowned neuro-oncologist. That's me. That's Dr. Srinivas Chilkuri. He looks after our pediatrics, thoracic, and GU work, and that's Dr. Ashwati, especially trained in Canada for hepatobiliary and GI cancers. That's the team of our physicists and radiation therapists, very well-trained and also very enthusiastic about what they do. We are also very privileged to be working in a setup which is site-specialized. So this is our two teams of head and neck and breast. There wasn't enough space to add the gynae team, and Dr. Kumar Gubala is here, who's a part of our gynae team. So this is our head and neck team, surgeons and oncodentists, the swallowing therapist, medical oncologists, as well as dedicated radiologists. This is our breast cancer team. That's Dr. Bhavna, whom you will be meeting. That's Dr. Selvi and Dr. Asha, part of the surgical team. I thank you very much for your attention, and I look forward to our discussion.